Okay, good morning, good afternoon, good evening, colleagues and friends, and happy Sunday. The kidney transplant recipient can present, as you all know, with proteinuria. And much like native kidney disease, we encounter three major forms of proteinuria in this group of patients: glomerular, tubular, and overflow. In all the years I've been practicing transplant medicine, I have never seen orthostatic proteinuria in a kidney transplant recipient, although I suppose it's quite feasible. Glomerular proteinuria presents in three flavors. One of them is recurrence of primary glomerular diseases, which Dr. Richard Glassock a few weeks ago presented a superb discussion on the subject. De novo glomerular diseases, which Dr. Agnes Fogo will discuss in 2022, and transplant glomerulopathy, which is, for all practical purposes, the most common form of nephrotic range proteinuria following transplantation. It was very easy to identify the right speaker for this subject, and that is Dr. Lynn Cornell, who has written extensively in areas such as interstitial nephritis, IgG4 diseases, as well as renal transplant pathology. Dr. Cornell is the professor of laboratory medicine and pathology at the Mayo Clinic in Rochester, Minnesota. She completed a residency in anatomic and clinical pathology at Massachusetts General Hospital under the leadership of Dr. Robert Colvin. She, under his direction, also completed a fellowship in renal pathology. And not only that, but she also received the Ruth Kirstein National Research Service Award by the NIH for her to undergo a postdoctoral research fellowship under Dr. Colvin. Much like a previous speaker, Dr. Cornell received the Gloria Gallo Research Award from the Renal Pathology Society, which is a very unique accomplishment. She's an outstanding educator, and as such, she has implemented the Renal Pathology Fellowship Program at the Mayo Clinic in 2013 and currently serves as the program director. I think we will all enjoy this discussion and we look forward to it. Dr. Cornell, the audience is yours. Thank you.
Well, thank you. Here, I'll share my screen. Okay, do you see it with my arrow here?
Yes.
Oh, okay. Well, thanks. Thanks for having me. I really enjoyed this whole GlomCon series, so I appreciate being part of it. So today I'm talking about transplant glomerulopathy, a pathologist view, because I'm a pathologist. Transplant glomerulopathy is a disease pattern of injury. It's not exactly a diagnosis by itself, it's a pattern of injury. And it's characterized or defined by glomerular basement membrane duplication. And typically when we are talking about transplant glomerulopathy, we are talking about it by definition in the absence of immune complex deposits. I'll show you some pictures of transplant glomerulopathy here. This is in a silver stained section. We can see glomerular basement membrane duplication. Remember, the basement membrane stains are the best to appreciate this. So that would be on routine cases, the silver stain or the PAS stain section. So you can see here glomerular basement membrane duplication. You can also see some marginated inflammatory cells here, which are mononuclear cells, and some enlarged endothelial cells. And speaking of endothelial cells, occasionally you can see, like the arrow is pointing to here, endothelial mitotic figures. And that also shows you that this is really an endothelial disease. And look here, this particular glomerulus, I saw it the other week. It has two endothelial mitotic figures in a single glomerulus. Now, by electron microscopy, we can see glomerular basement membrane duplication, which the red arrows are pointing to here. And also, I had talked about endothelial cells being activated. You can see this large endothelial cell with loss of fenestrations that the blue arrow is pointing to. And just for comparison, here's a normal glomerulus where you can, with the green arrow pointing to normal endothelial cells with preserved fenestrations. You can see how enlarged endothelial cells are in that case of transplant glomerulopathy. And here's a more severe transplant glomerulopathy where you can see the original basement membrane out here in the glomerulus and all of these layers of basement membrane that are being formed. And here is a tiny little lumen here. So this is a severe case of transplant glomerulopathy. So most cases of transplant glomerulopathy are due to chronic antibody-mediated rejection. And we think this is because there is chronic or episodic antibody-mediated damage to the endothelium. And when the endothelium is damaged, it likes to repair itself and as part of that process, for some reason, lays down a new basement membrane layer. Now, today I'll be talking about this classification system, the BAMP schema, which is the most commonly used in transplant pathology and in rejection. And to diagnose chronic antibody-mediated rejection in the BAMP schema, we use these three criteria. First is histology, which is chronic tissue injury attributable to antibodies. So that would be, for example, transplant glomerulopathy, which would be the most well-recognized form of chronic antibody-mediated rejection. Second, we need evidence of recent antibody interaction with the endothelium. This is usually C4D, but we can also use peritubular capillaritis and glomerulitis as evidence of that antibody interaction. And third, donor-specific antibody, or TSA, which is usually against the HLA expressed on the endothelial surface. So what we think is going on in C4D positive antibody-mediated rejection, at least in the acute setting, is that we have the graft endothelium that's expressing the HLA. There's circulating donor-specific antibody that recognizes that HLA. That antibody then activates complement by the classical pathway. And eventually we end up with complement-mediated endothelial injury. And where does C4D fit into here? Well, C4D is a split product of the complement component C4, and it binds covalently to the site of antibody activation of complement. So in this case, the endothelium. And it stays around for about 1 week after activation of complement. So it's a good marker of more recent complement activation. We can do C4D staining on our kidney biopsies by immunofluorescence or by immunoperoxidase. And in these cases, we are looking at the peritubular capillaries. And of course, they have a lot of endothelium there. Then that's generally what we're looking for when we're staining for C4D and evaluating for antibody-mediated rejection. Now, what about C4D staining in transplant glomerulopathy? Well, it may be negative or focally or multifocally positive or diffusely positive. And depending on the series that you are looking at, it's positive in about 20 to 40% of cases of transplant glomerulopathy that are due to chronic antibody-mediated rejection. So remember that you can have chronic antibody-mediated rejection and transplant glomerulopathy that's due to antibody-mediated rejection. And sometimes in the majority of cases, they will be C4D negative, but it's still due to an antibody. So why is this? Well, we know that the antibody levels can fluctuate post-transplant, and these may be associated with episodic C4d positivity and endothelial injury and repair. So if we're looking post-transplant, we'll have the serum DSA concentration rises or falls below the level of detection, and we have corresponding C4d positivity in peritubular capillaries. So depending on whatever time you happen to take your biopsy, if you take it when there are lower serum antibody levels, then you may have C4d negative staining in your kidney biopsy. And if you take it when you have higher DSA levels, then you'll have positive staining. Now, there was a paper a few years ago that looked at different causes of transplant glomerulopathy, this histologic pattern. And they found, in addition to chronic antibody-mediated rejection, other causes were possible, including particularly hepatitis C infection and thrombotic microangiopathy. And in this study, there was a significant overlap between hepatitis C infection and thrombotic microangiopathy. Now, there was a more recent study I'll talk about a little bit later that actually found a pretty low prevalence of hepatitis C infection in their transplant patients. And this may be less of an issue moving forward now that we have pretty effective treatments for hepatitis C. Now, I'm going to go through a few cases of transplant glomerulopathy. This biopsy is from a 23-year-old woman who had end-stage renal disease due to focal segmental glomerulosclerosis, possibly a secondary FSGS, and she underwent this biopsy 1.5 years post-transplant. You can see there's something going on in the glomeruli. Well, looking more closely, you can see glomerular basement membrane duplication. The arrows are pointing to that. So this looks like a case of transplant glomerulopathy, right? So what's your diagnosis? I'll give you a little more information. The C4d was negative, and she had no history of donor-specific antibody. Well, let's look into the clinical history. The patient had developed a post-transplant lymphoproliferative disorder, diffuse large B-cell type that was EBV positive. She underwent chemotherapy with R-CHOP initially, and then she underwent additional chemotherapy after she had recurrent PTLD. She also had undergone autologous stem cell transplantation 6 months prior to this biopsy. So our diagnosis in this case would be chronic thrombotic microangiopathy. There was really no evidence of antibody-mediated rejection, and all of these conditions, a malignancy, chemotherapy, and even autologous stem cell transplantation have been associated with thrombotic microangiopathy in native kidneys and also can occur in transplant kidneys. Now, here's another case, a 78-year-old woman with end-stage renal disease attributed to hypertension. This biopsy was done 3 years post-transplant for increased creatinine. You can see there's something going on, maybe in the glomeruli, also a little tubular atrophy here. As you can guess from the topic of this talk today, there is a pattern of transplant glomerulopathy. You can see glomerular basement membrane duplication here. And on electron microscopy, you can see the subendothelial lucency and also early glomerular basement membrane duplication, along with enlarged reactive appearing endothelial cells. And I'll talk about peritubular capillaries more later, but peritubular capillaries showed a similar finding with basement membrane multilayering. So what's the diagnosis here? I'll tell you the C4d was negative, but the patient had angiotensin II type 1 receptor antibodies. So the diagnosis here was a glomerular microangiopathy and peritubular capillary, possibly representing antibody-mediated rejection due to a non-HLA antibody. And I put in this reference here. This group has written other articles about this, but occasionally we do have antibody-mediated rejection that may be due to non-HLA antibodies. Sometimes these are C4d positive, but in this particular entity tends to be C4d negative. Now, immune complex glomerulonephritis can give you a light microscopy pattern of transplant glomerulopathy. And this can be recurrent or de novo immune complex glomerulonephritis. It includes IgA nephropathy, C3 glomerulonephritis, any kind of immune complex glomerulonephritis that will give you subendothelial deposits can give you glomerular basement membrane duplication and the light microscopy appearance of a transplant glomerulopathy. So this just stresses that we also need to be doing immunofluorescence and electron microscopy studies to determine the diagnosis, not just light microscopy. Here's a case of a 45-year-old woman who had end-stage renal disease labeled as membranoproliferative glomerulonephritis. The biopsy, this biopsy was 13 months post-transplant. Her creatinine was elevated and she had 4 grams per day proteinuria. You can see the glomeruli do not look normal from this lower magnification. You can also see some interstitial inflammation. You may be thinking this could be rejection. We can see some glomerular basement membrane duplication on higher magnification on the silver stain section. So what did the immunofluorescence show? Well, we can see staining in the glomeruli for granular staining for IgG, C1q, C3, and kappa light chain, but negative staining for lambda light chain. So when we see this, we're thinking of a particular entity. And the pathologist in this case did staining for IgG subclasses and then stained only for IgG3. The glomeruli were negative for IgG1, 2, and 4. Also, by electron microscopy, you can see subendothelial immune complex type deposits with surrounding glomerular basement membrane duplication. And that's why we have the glomerular basement membrane duplication that we see on light microscopy because of these subendothelial deposits. So the diagnosis here was a proliferative glomerulonephritis with monoclonal IgG3 kappa deposits, and this was recurrent. And we need to remember that sometimes patients may have had their native kidney biopsies many years ago, decades ago even, and we sometimes will make the diagnosis of the native kidney disease when it recurs in the transplant. And also remember some of these diseases, such as this disease, PGN-MID and C3 glomerulonephritis, some of these glomerular diseases weren't even defined not even described at the time of the patient's native kidney biopsy. So just keep that in mind when we are thinking about patients who have a transplant and are getting proteinuria. Now, here's another example of a patient who had a kidney biopsy 10 years post-transplant. The biopsy showed glomerular basement membrane duplication and subendothelial lucency, and this patient had de novo donor-specific antibody. And look by electron microscopy, this subendothelial lucency, and we're getting some early basement membrane duplication by electron microscopy. So of course, with de novo DSA, we're thinking of chronic antibody-mediated rejection, and I think that is the case. But this particular biopsy also showed some subendothelial deposits, and by immunofluorescence showed IgA dominant deposits. This patient actually had a native kidney disease of IgA nephropathy, and this represents recurrent IgA nephropathy in addition to chronic antibody-mediated rejection. So sometimes we can have 2 disease processes going on, and in these cases, electron microscopy is especially helpful, so you can see the areas that show the antibody-mediated rejection process and see other areas that show immune complex deposits. Okay, I know this is the GlomCon, but let's look beyond the glomerulus for a few minutes and discuss some other tissue injury patterns that are seen in chronic antibody-mediated rejection. In addition to transplant glomerulopathy, we can see peritubular capillary basement membrane multilayering, or PTC-BMML. This is also called peritubular capillaropathy. And another pattern is transplant arteriopathy. Peritubular capillary basement membrane multilayering is basically a transplant glomerulopathy of the peritubular capillary, and you can see not just one layer, but multiple layers here. This particular case would be graded as severe. You can see so many layers here, which is more than 7 circumferential layers in the peritubular capillaries. You can also see reactive appearing endothelial cells. This hardly even looks like a peritubular capillary here, actually. And just for reference, here's a normal peritubular capillary with a single basement membrane layer. And here we have another example, higher magnification, with numerous basement membrane layers and again, reactive appearing endothelial cells. And sometimes we can, if we have a nice silver stain section, we can see this peritubular capillary on the light microscopy as shown in this case. So transplant arteriopathy is another histologic lesion associated with alloantibody. And this is when we see arterial intimal thickening that's due to rejection. And this is a pattern that we can see in chronic antibody mediated rejection or in chronic T-cell mediated rejection. So here we can see the thickened intima here. This is all new fibrous tissue. And you can see some inflammatory cells that are in that thickened intima. And quite commonly, I get immunostains for CD3 and CD68 to try to identify these inflammatory cells in the thickened intima. So then I can say that this is a lesion of rejection rather than something seen in hypertension or possibly donor disease. Here is a case of severe intimal thickening in this artery. Look at that tiny lumen here. And this was actually a patient who had antibody-mediated rejection. There was a paper several years ago from the French group that looked at the vessels in patients with donor-specific antibody, and they found this accelerated arteriosclerosis. And histologically, they found this could be indistinguishable from arteriosclerosis due to hypertension. So in these kinds of cases, it's helpful to have several biopsies, maybe a time-0 biopsy, so that we know that there is accelerated arteriosclerosis, and then we can attribute that to antibody. So what are some other histologic changes that are associated with alloantibody? Well, we can see peritubular capillaritis and glomerulitis. This is when we see margination of mononuclear cells and neutrophils. Sometimes it's called microvascular inflammation or MVI. This is associated with later development of transplant glomerulopathy, and it's considered an active feature of antibody-mediated rejection in the band schema, but keep in mind that these biopsies may or may not be C4d positive. If we do immunostaining on these cases of capillaritis, you can see that the cells are a mixture of CD68 positive monocytes, macrophages, and CD3 positive T cells. So when do we see this kind of lesion? Sometimes it's called subclinical antibody-mediated rejection. Well, there was a large study of over 1,000 protocol biopsies at 1 year, and they found about 14% of these patients had subclinical antibody-mediated rejection or this microvascular inflammation capillaritis. And of those with microvascular inflammation, 32% were C4d positive. All of the patients had serum donor-specific antibody at the time of biopsy, either pre-existing, so prior to transplant, or de novo donor-specific antibody. And the 8-year graft survival was lower compared to those that did not have this lesion, 56% versus 90% with no rejection. Now that was at 1 year. At 5 years, at Mayo Clinic, we do 5-year protocol biopsies. And we had this one study that looked at histologic features associated with alloantibody in our patients who are positive cross-match or ABO incompatible or conventional with a negative cross-match. And you can see the rate of transplant glomerulopathy in positive cross-match transplant patients was 58%, also about 70% rate of glomerulitis and peritubular capillaritis. So quite a common lesion at 5 years, also compared to a low rate of these histologic changes in ABO incompatible or conventional negative cross-match transplants. So let's talk a little bit about what are the causes of late graft dysfunction. So there was one study who had that looked at patients who had indication biopsies at more than 1 year post-transplant. And those patients who underwent biopsy frequently had donor-specific antibody, especially anti-HLA class 2 antibody, and also frequently had glomerulitis or peritubular capillaritis or transplant glomerulopathy. And they found that 63% of the late kidney failures after these biopsies were attributable to antibody-mediated rejection. Although this is kind of a small study, only 27 late kidney failures. So at Mayo Clinic, my colleagues also had looked at causes of graft loss in over 1,300 conventional recipients. So these are patients who did not have a positive cross-match kidney transplant. And my colleagues had studied about 150 patients who had graft loss that was death censored. And what were the causes of graft loss in these patients? 153 losses, well, 37% were lost due to glomerular disease. And what were these glomerular diseases? Well, 15% were transplant glomerulopathy, 15% recurrent disease, and 7% de novo disease. So overall, about 15% graft loss due to transplant glomerulopathy. Presumably, these were mostly chronic antibody-mediated rejection. Now, more recently, we looked at our late or 10-year post-transplant protocol biopsies in conventional kidney transplants. And what we found was predominantly glomerular and vascular changes with mild or no interstitial fibrosis and tubular atrophy. So here we can see an example of a 10-year protocol biopsy with increased global glomerulosclerosis. Other findings that we found were mesangial expansion, whether or not patients had diabetes. This particular patient did not have a history of diabetes, and arteriolar hyalinosis was quite common in essentially everyone at 10 years. And what about chronic antibody-mediated rejection, transplant glomerulopathy? Well, only about 12% of patients at 10 years had transplant glomerulopathy. So it is a pretty relatively low rate. Remember, these are functioning grafts and these are protocol biopsies. So we may have an increased rate of these findings in indication biopsies. But that gives you, it puts it into perspective of what is causing late allograft injury. So what about transplant glomerulopathy prognosis, and what's the association with C4D and donor-specific antibody? Well, we know that transplant glomerulopathy has a poor prognosis, the 50% graft loss at 5 years after the diagnosis. And you can see in this graph, death-censored graft survival after transplant without transplant glomerulopathy. You can see quite good, over 90% 5-year survival. With transplant glomerulopathy, you can see it drops off here. And many of the grafts are lost by 5 years. Now, there was this study, DCAF study, that looked at antibody-mediated injury, which was either donor-specific antibody positive or C4D positive, and they found it was pretty common, 57% in patients with new onset late graft dysfunction. And they found that the risk of graft failure was significantly worse if the C4D was positive. You can see these two lines here, C4D positive, C4D negative is up here. And this was whether or not they had donor-specific antibody. So it had a worse prognosis if it was C4D positive, whether or not there was donor-specific antibody in the serum. Now, what about these anti-HLA? Well, they are antibodies. They are particularly associated with, or transplant glomerulopathy is particularly associated with anti-HLA class 2 antibodies. In the study from my colleagues at Mayo Clinic, they found that pre-formed, so pre-transplant donor-specific anti-HLA2 antibodies were associated with later development of transplant glomerulopathy. You can see the graph here with no anti-HLA class 2 antibodies, here with anti-HLA class 2 antibodies in a lower level. And if patients had higher levels of anti-HLA class 2 antibodies, you can see the risk of developing transplant glomerulopathy was much higher. And what about C4D staining? Well, you can see here, let's see, with patients without transplant glomerulopathy, 530 patients, they have very good graft survival up to 4 years. C4D negative transplant glomerulopathy is intermediate, and C4D positive transplant glomerulopathy drops off like this with the graft survival. So what happens when there's no anti-HLA donor-specific antibody? Well, there was this recent paper that was published just August 2021, where they had 954 patients who underwent kidney transplantation during this time period. They found there was the worst graft survival with transplant glomerulopathy when the patients had positive anti-HLA donor-specific antibodies. So you can see the graft survival in this red line here drops off here. And transplant glomerulopathy without donor-specific antibody, they concluded may represent a different mechanism of injury because the prognosis was much better. So we've been talking about C4D, which is an indicator of complement activation. I'll just say a few words about the possible role of complement in chronic antibody-mediated rejection. At Mayo Clinic, I was involved in a study that was initially evaluating patients who underwent kidney transplant with a positive cross-match. And we were trying to see if eculizumab, which is a terminal complement inhibitor, it's against complement component C5, to see if treating with eculizumab prior to transplant and early post-transplant would prevent early antibody-mediated rejection in positive cross-match kidney transplants. So just keep in mind when I'm discussing this that the study was designed to prevent early acute antibody-mediated rejection. It wasn't designed to prevent chronic antibody-mediated rejection. So again, here is this graph, and you can see, or this schematic, you can see eculizumab works here. It's an antibody against C5, which then blocks the terminal complement and prevents formation of the membrane attack complex. So what happened to these patients after the initial 1 year study period, initial few months study period? We followed these patients out, of course, and you can see for patients at 3 months, they had pretty, compared to controls, about 20 to 30% rates of capillaritis that was moderate to severe at 1 year, and then 2 years, also similar to controls, they had commonly had moderate to severe peritubular capillaritis. Now, these patients were also followed out to 5 years and had, many of them had 5-year protocol biopsies. And just look at transplant glomerulopathy here. Now, remember, these patients were only treated early. They weren't on eculizumab the entire 5 years, not to mention the expense of that. But look at the rates of transplant glomerulopathy within the control group and the eculizumab treated group early on. You can see the similar rates of transplant glomerulopathy at 5 years on their protocol biopsies, in addition to these other features of antibody-mediated rejection with glomerulitis and peritubular capillaritis. So what are the possible mechanisms of chronic antibody-associated injury? Well, I think from the evidence of lower rate of C4D staining in these, and also from the eculizumab study, complement by itself is likely not critically important. So one possibility is that we can see direct injury to the endothelium by antibody. And we know from in vitro studies that HLA class 1 alone can stimulate endothelial changes. So from this, we can conclude that complement is not necessary to cause endothelial injury or endothelial proliferation. There was another study in mice that found that non-complement fixing donor-specific antibody can produce endarteritis and chronic transplant arteriopathy in complement deficient mice. This is in a heart transplant model. Now, another study or another possibility is that C4D and complement only may be responsible for producing these changes. And as we know from that DCAP study that I discussed earlier, C4D positive transplant glomerulopathy had a worse prognosis. So maybe it's independent of antibody, possibly complement alone could be causing late injury. I think there is a third possibility too, and that is a sensitized cellular response in patients who have positive cross-match or have donor-specific antibody. And this is when we see this capillaritis, the glomerulitis and peritubular capillaritis, and the cellular infiltrate actually may drive the chronic injury. And we know that this glomerulitis and peritubular capillaritis is most commonly associated with late graft injury rather than that early acute antibody-mediated rejection. I'll say a few words about our BAMP highly sensitized working group, also known as the Antibody-Mediated Injury Working Group. We sent out a survey of asking about clinical practices on antibody-mediated injury. And we sent out questions about 6 different clinical pathologic ABMR scenarios. And this was meant to represent the broad range of antibody-mediated injury that we may encounter clinically, ranging from acute to chronic ABMR, de novo, or preformed donor-specific antibodies, C4D positive and C4D negative, and with and without donor-specific antibody. And we asked questions about these. We had respondents from both transplant clinicians and renal pathologists, and we had survey respondents from 6 continents. I guess no one in Antarctica, the penguins didn't want to respond. So what did we find? That there was a discrepancy. The pathologists and the clinicians assigned an ABMR diagnosis that was different from the reference, the BAMP standard, overall about 30% of the time in these different questions. And what's more is that this discrepancy influenced treatment decisions. And what did we conclude here? We concluded that this term acute, previously the diagnosis in BAMP was called acute/active ABMR. That term is confusing. And this term, partly due to results of our survey, was removed from the BAMP 2017 schema. We also found that clinicians often fail to recognize the chronic elements of antibody-mediated rejection, such as transplant glomerulopathy. And clinicians were more likely to consider a diagnosis of chronic active ABMR if the C4D was negative, even if there was no transplant glomerulopathy, peritubular capillary, or even interstitial fibrosis or tubular atrophy on the biopsy. So we then conducted a follow-up survey in 2019 to address some additional questions that were raised by that first clinical practices survey. We found that most providers, 97%, said that they use the BAMP ABMR classification at least sometimes. But we also found that only about 20% of pathologists and 45% of the nephrologists and transplant surgeons reported that they always have the DSA results when the biopsy is available. So even though the DSA is part of the BAMF classification, it doesn't really make sense if people are saying they're using the BAMF classification, but they generally do not have access to donor-specific antibody information at the time that they're interpreting the kidney biopsy. So the key points here are that transplant glomerulopathy is a pattern of injury. The differential diagnosis includes chronic antibody-mediated rejection, as well as all different causes of chronic thrombotic microangiopathy, and to a lesser degree now hepatitis C infection. Immunofluorescence and electron microscopy studies are needed to show if we do have an immune complex glomerulonephritis that's causing this light microscopy pattern. Other ABMR features are capillaritis, peritubular capillariopathy, and transplant arteriopathy. Chronic ABMR is one of many causes of late graft injury. And transplant glomerulopathy is a poor prognosis. It's worse if the C4D is positive and if the patients have donor-specific anti-HLA antibodies, but we still know the role of complement is unclear in transplant glomerulopathy. And of course, there's more work to be done. Much of this work is being done by the BAMF working group, so I'd encourage you all to get involved with the BAMF process if you are interested. The next BAMF meeting was supposed to be next week, I think, but the BAMF conference due to COVID has been rescheduled to September 2022. So mark your calendars now. I've already requested my time off for that time. So hope to see you there. Hope we can visit beautiful Banff, Alberta at that time. Thank you, and I'm happy to take any questions.
Thank you, Dr. Cornell, for an outstanding presentation. This is, as the audience can gather, a very complex subject. And Dr. Cornell has really made it as simple as she can under the current literature circumstances. So what I'm going to do is I'm going to bring up some of the questions from the chat. Please do not add any more questions to the chat because we have lots of time for you to ask them personally after our IT department unmutes everybody, which will happen right after we answer all these questions. The first question comes from Dr. Patel, and he is mainly referring to when do you suspect the presence of a non-HLA antibody-mediated chronic rejection and perform stainings looking for these molecules?
Oh, I don't think we can do anything on the kidney biopsy to look for these. I think that's mostly done by the serum and the HLA lab. So they can look for non-HLA antibodies. But the testing is difficult. We don't do much testing of non-HLA donor-specific antibody at Mayo Clinic. I didn't discuss it that much, but of course there are a variety of potential non-HLA donor-specific antibodies. There's MIC-A, which has been reported on, and I believe we test for that at Mayo. Also anti-endothelial antibodies. That's a more difficult, it's more difficult to test for those. So sometimes testing for anti-endothelial antibody, and again, I'm not an HLA expert, but I understand that for testing for anti-endothelial antibodies, either you can get endothelial cells from the donor. So that would require having a living donor that's available and able to donate blood to get endothelial cells and extract those from the blood. Otherwise, they can use a surrogate endothelial cell, but that testing is difficult. For MIC-A, I know that there are some beads available that can test for those, but it's difficult, and it's, I think probably more of an evolving area in the HLA lab testing. And again, I'm not an expert in that, but I think it's less common than anti-HLA antibodies, certainly.
Thank you. I mean, for those interested in the area of non-HLA antibodies, which is an up-and-coming interesting story, the American Society of Transplantation has every February a meeting in Arizona called the CEOT meeting, the Cutting Edge in Organ Transplantation, and this area will be thoroughly discussed by an extraordinary group of people. So those that are interested, please email me and I'll send you the information. At the moment in the country, the group at Cedars, the group in Canada, and there are some other smaller groups are working in this area. Dr. Singh had a question. If you find C4D, does that mean entrapment or this is the real thing?
I think you're talking about glomerular C4D. So we can do C4D staining by immunofluorescence technique or by immunoperoxidase. By immunofluorescence, glomeruli normally show some staining for C4D, having nothing to do with a transplant, anything. They just normally show some staining, especially granular mesangial staining. So we don't really interpret that just because they do. That's why we look at the peritubular capillaries. Yeah, I think that represents entrapment. By immunoperoxidase, we don't see staining of glomeruli normally for C4D. So we can interpret the glomerular staining by that technique and presume that it's due to antibody-mediated rejection. Now, I didn't go into detail about this, but there are, pluses and minuses of both techniques. By immunoperoxidase, sometimes you can get serum staining, and of course there's C4 in the serum. So depending on whatever happened to that particular biopsy, you can see some of that serum staining, and it can look like capillary staining by that particular technique. So anyway, you just have to be careful when you're looking at that. So sometimes you can, that's just a technical issue. So, so just different things to keep in mind if you do see glomerular capillary staining for C4V.
Great. Dr. Kelber wanted to know the frequency of associated tubular and vascular changes that you may encounter in cases of transplant glomerulopathy.
Peritubular capillaritis. I'm looking at the custody here. How often peritubular capillaritis is associated with transplant glomerulopathy? Essentially, always when it's due to chronic antibody-mediated rejection. So a couple of things that I didn't mention in this talk is that a couple of things to think about. First, when you have a long-standing antibody-mediated rejection, that affects capillaries in the glomeruli, also can affect the peritubular capillaries, of course. But we also can have disappearance of those peritubular capillaries. So sometimes you might say, well, how bad is the peritubular capillaritis, in this advanced chronic transplant glomerulopathy? And you actually say, well, there isn't that much peritubular capillaritis because the peritubular capillaries aren't there, or they're really small. And I did show some examples of peritubular capillary basement membrane multilayering. So they actually, when it becomes really severe, those capillaries disappear. So sometimes I also get a stain for CD34, which is an endothelial marker, to see how many peritubular capillaries there are, to see, and that basically tells you, there aren't capillaries to show that capillaritis, but basically you always see capillaritis. And the other thing I'll mention is that these scores aren't necessarily that reproducible. And we had done a study from Mayo Clinic that I also didn't talk about today, but looking at reproducibility of the different antibody scores. And, I think if you know someone has donor-specific antibody, you know that they have C4D positivity, or you know they have transplant glomerulopathy, you think it's due to antibody rejection, you will look more closely for peritubular capillaritis. So that's another issue too, is the reproducibility of these scores.
Great. iPhone, I don't know who iPhone is, but iPhone asks, if you find CD3 in the biopsy, does that mean there is a superimposed T-cell mediated rejection?
Yeah, so as I mentioned, I often get a CD3 and CD68 stain on my kidney biopsies when I'm looking for transplant arteriopathy. The problem with doing those stains is that you see a lot more interstitial inflammation than you appreciate by light microscopy. So it's not that the inflammatory cells aren't there in your biopsy, it's just that they're really highlighted when you get the stain. So you're kind of surprised, like, whoa, was there actually cellular rejection? So you kind of have to, take a step back when you're doing those stains, I think, because the definition, and maybe one of the people here also would like to comment on that. We're supposed to, I believe, grade ours on the light microscopy appearance. And but anyway, there's certainly inflammatory cells there, but unless I see actual on light microscopy, routine stains by light microscopy, unless I see the features, including tubulitis, that would qualify for a concurrent cellular rejection, I don't call it a concurrent cellular rejection. The other thing to think about is when you're doing immunoperoxidase staining for CD3, for example, that will highlight the peritubular capillary inflammatory cells. So it's not actually interstitial inflammation. So that the peritubular capillary inflammation isn't part of the cellular rejection diagnosis.
Great.
And it doesn't, the immunoperoxidase stain doesn't, there's a counter stain there, but it doesn't, at least in our lab, it doesn't really highlight the structures that well to tell exactly where those inflammatory cells are.
Great. So Dia, if you can please unmute the audience so they can ask pertinent questions. The first one, I think Dr. Rondawa from the University of Pittsburgh has some comments.
Hey, Lynn, very nice talk, extensive literature review, beautiful pictures. I enjoyed it. I had a comment that this C4D performance varies somewhat from lab to lab. For example, when we do the C4D on immunofluorescence, we always see linear staining of the glomerular basement membranes. And of course, we have learned to ignore it, but it's always there. And we're not able to get rid of it. On the other hand, when we do a formalin fixed staining, the entrapment of the C4D appears to be non-specific. In other words, I will see it in diabetic nephropathy. I will see it in ischemic glomerulopathy. And I think some other workers like Volker have seen the same thing. In other words, it can be a non-specific entrapment. And a very important practical point is that if you see C4D in the glomerular basement membranes, then you have to think of membranous nephropathy or MPGN. That's sometimes the first time, it becomes apparent, that possibility. And the other comment I wanted to make is one of a historic nature, like in the early 90s, chronic transplant glomerulopathy was attributed entirely to T cells. And now people don't even mention chronic T cell mediated rejection in the differential. So I think this is an extreme polar swing of view. Of course, in the current era, when we see it, most of it is antibody. But when we don't see it, there's no C4D, there's no DSA, we start chasing non-HLA antibodies, we start chasing NK cells. But we have to remember that in any glomerulitis or chronic transplant glomerulopathy, 30 to 40% of the cells are in fact T cells. So it's and those T cells are producing granzyme and they are active. So it's very likely that chronic T cell mediated rejection is a contributing element and sometimes even the predominant element when clearly there's no good evidence for antibody.
Yeah, I agree. Great points. Thanks. Yeah, and about the membranous issue, yeah, sometimes, of course, different labs have different practices, and it's important to keep this in mind when we're looking at studies from different hospitals, and also interpreting biopsies if they were stained at different hospitals too. And then some institutions, including ours even, will do, maybe we'll do light microscopy only on a biopsy, depending on the clinical history, and then we'll do selected immunofluorescence stains, like C4D only, or the full immunofluorescence panel on a protocol biopsy, for example. But exactly, if I see that kind of staining, granular glomerular basement membrane staining, then I'm thinking out of membranous, which could be recurrent, of course. It's quite common to have recurrent membranous. 50% of grafts, patients with a history of membranous, of recurrent membranous, at least on protocol biopsies, or de novo membranous, which is also associated with donor-specific antibody and chronic antibody-mediated rejection. But that will make you think, yes, I have to do the full immunofluorescence panel, and ideally also do electron microscopy to try to make that diagnosis of membranous glomerulonephritis. Yeah, great points.
Now, one more point, if I may.
And about the T-cell mediated rejection too. Okay,
no, it won't be on TCMR. Okay, it's on ABMR. So there are these different combinations of things which lead to the diagnosis. Sometimes the DS is negative, sometimes the C4D is negative. And of course, these can be due to technical reasons, as you very well pointed out. But at the same time, we should not lump all of them into ABMR period. For example, if there's ABMR and the C4D is negative, you should perhaps think twice before you give eculizumab. And if there's ABMR, C4D is positive, DSA is not demonstrable, then maybe you should think twice before starting plasmaphoresis. I mean, these are just thoughts to consider. Like all ABMR is probably not one uniform mechanism.
Yeah, I agree. And I see in the chat, there was another question about plasmaphoresis and transplant glomerulopathy, I think. Oh yeah, role of plasmaphoresis in transplant glomerulopathy due to ABMR.
Well, actually,
yeah, there isn't a great treatment for chronic antibody-mediated rejection, and there are clinical trials now, with different, novel immunosuppressants and things. But what is the role of plasmaphoresis? Well, in antibody-mediated rejection in general, I think unless you have high DSA levels, and corresponding C4D positivity, that you don't have anything to remove from the serum. If you're having low levels of DSA and ongoing, antibody-mediated rejection, you don't have anything to remove, so plasmaphoresis wouldn't even do anything. I think sometimes people are just doing plasmaphoresis because it's not a very toxic therapy, and it just shows that they're trying to do something, but probably isn't doing much, except in the acute setting. If you have a really more acute antibody-mediated rejection, in addition to some chronic changes, then potentially, some of these treatments like plasmaphoresis or eculizumab might be helpful in the, if there is a component of acute ABMR.
Yeah, and that's an excellent point, which I'm glad you brought it up. I mean, there is no treatment whatsoever for chronic antibody-mediated rejection that has been proven to be effective. There are trials with interleukin-6 blockers now in certain centers, which you can find them at the AST website. But the main treatment of chronic antibody rejection is preventive. And that has to do with the role of under immunosuppression, either on the patient's part or in the healthcare giver. And I want to bring up an issue that is important, and that is the role of electron microscopy in the early detection of chronic antibody-mediated rejection, as it has been shown by Dr. Mark Haas. Now, a doctor, there is a doctor's, my apologies.
And I'll just add something about clinical trials. There have been clinical trials looking at really short-term outcomes, like 6-month biopsy changes 6 months after, patients were enrolled in the trial. 6 months is not a long enough time to see any of these changes. This is a many-year process. So there is this clinical trial now that's looking at 5-year outcomes, and that's really more appropriate to look at 5-year outcomes with an experimental drug when we're looking at this. The problem is that, drug companies, everyone wants something sooner than 5 years, but it's really going to take that time, and it's going to be wasted, resources if we aren't looking at longer term outcomes.
Great. By the way, Dr. Qasim Safa from Mass General has posted a nice review on Antibody, on AMR actually. So will be worth downloading and reading. Any other questions from the audience, please ask them now.
It looks like Sam El-Badri has a question.
Okay, go ahead.
Yes. Hi, this is Sam from Minnesota, Hennepin Healthcare. So an excellent lectures from Dr. Cornell. Just if you can give a comment about the immunostains for CD3 and CD68. I know you mentioned some indications. So do you recommend it to do the immunostains in all transplant settings? So makes life easy for assess the extent on inflammation. What's the disadvantage of doing as a routine CD3 and CD68 in all transplant settings?
Yeah, the disadvantage is that you'll see a lot of inflammatory cells that you didn't want to see. They may be in atrophic areas, so you don't really count them for acute rejection. They may be in peritubular capillaries, so they don't count for cellular rejection. I do the stains just to evaluate arteries if I'm worried about a transplant arteriopathy, but I don't do them generally. Other than looking for transplant arteriopathy, if I'm not 100% sure those are inflammatory cells, I don't do those stains. So no, I don't recommend them for those reasons.
I think you'll have to recalibrate your whole reading process. What you've been used to doing for months and years, you'll have to relearn again, because you'll see an absolutely different picture in every biopsy. So it is not recommended for that reason.
Yeah, and Parmjeet, you had talked about how we used to think about T-cell mediated rejection, and now everyone thinks about just antibody mediated rejection. Well, Sam El-Badri has done a study with me, not submitted yet, but looking at this unusual lesion of acute allograft glomerulopathy, which is really rare in transplants, but it's highly associated with endotheliolitis. But it looks like glomerulitis with really reactive appearing endothelial cells, and in our study not associated with, by design it was not associated with donor specific antibody, and by definition these were C4d negative, so but highly associated with endotheliolitis, and I think that represents a T-cell mediated rejection, kind of like an endotheliolitis that happens to occur in the glomeruli. And does that lead to transplant glomerulopathy? Possibly.
I think we should recognize T cells more often, because people are deprived of the only treatment that's available. There's treatment for T cells, and unfortunately, we don't diagnose it as often as you should. Often it's present in addition to antibody.
Right. And again, that also depends on your center and the patients at your center and your mix of patients, the ages, deceased donor versus living donor, how adherent they are to the immunosuppressive medications and these kinds of things. Also, what's the routine immunosuppression at the center? We get kidney biopsies from Mayo Clinic, and also we get transplant biopsies from other centers that are sent in. So we really see different rates of rejection at these different places. So everyone keep that in mind. What we see at Mayo Clinic might not be what everyone sees everywhere else. Other places may maybe see more combined cellular and antibody mediated rejection.
Okay, so it's that time. I mean, Dr. Cornell, this was fantastic. Thank you. Kudos from a lot of the members of the audience to you. Interestingly, there was somebody that I'm sure you know in the audience by the name of John Cornell, who also is a very proud individual and enjoyed thoroughly your talk. You know who that person is. And
that is another Dr. Cornell. That's my dad.
I know. And Dr. Wages-Pack has posted another interesting paper, which I will urge you to read, which I think is the same paper that Dr. Qasem Safa plays, but I'm not sure. I need to check them out later.
I think one is a link and one is the PDF. Some were having trouble downloading the PDF.
Oh, I see. Thank you very much. And so, Lynn, thank you again. Marvelous discussion. And please, you all enjoy your Sunday. Good day.
Okay. Thanks, everybody.
Bye.
Bye.